Hi, my name is Dr. Joe Cayas. I'm a child and adolescent psychiatrist, and I am currently the Director of Child and Adolescent Psychiatry for the Psychiatry Residency Training Program for Michigan State University Kalamazoo Center for Medical Studies in Kalamazoo, Michigan. I'm also an Associate Professor of Psychiatry for Michigan State University. I'm pleased to be here today to talk about a very common problem that we see in a clinical setting, and that is aggressive and self-injurious behaviors in both children and adolescents with developmental disabilities. The overview is going to be looking at some terms, definitions, a little bit about the epidemiology in general, evaluation, medication trials in general, and then looking at both aggression and self-injurious behavior, more specific interventions. The terms that we're all familiar with, but just to review, are DD, meaning developmental disabilities, ID, intellectual disabilities, MR, mental retardation, and LD, learning disabilities. Now, in the United States, LD usually means things like reading disorder or mathematics disorder, but in the UK, it's very common for that to be synonymous with DD, ID, or MR. We're also familiar with PDD, pervasive developmental disorders, or more commonly nowadays referring to that spectrum as the autistic spectrum disorders, or ASD. And finally, SIB, or self-injurious behavior, and DSH, which deliberate self-harm, which is usually more likely to be found in the European literature than it is in the United States, because DSH is not a PubMed mesh term the way SIB is. So definitions, aggression, we usually define as any behavior that threatens or actually inflicts harm, and it can be divided into either verbal or physical. Physical aggression can be directed towards property or towards person or people, and aggression involving people can either be directed towards others, and the other term for that we use is violence, or towards the self-injurious behavior. So a very brief epidemiologic comment. We know that there are a lot of problems in the literature as far as having the same terms, different sampling techniques, that sort of thing. But generally the prevalence rate for aggression in the DD population, looking across all ages, is somewhere between 2% and 20%. So we always want to start out with a good evaluation, which means a good history and physical examination. However, with the populations that we're looking at, an accurate history isn't always going to be available. So we have to take their cognitive and communication skills into consideration, and we especially have to look at collateral sources. So for those who are living in a structured environment, a residential setting, we would ask the staff, other caregivers, to give us that information. We should always do a behavioral assessment. Always the ABC principles of looking at antecedents to the behavior itself in descriptive terms, and then the consequences to the behavior. Remember that it's important for us to report what we sense with our seeing, our hearing, etc., not what we surmise might be going on. In other words, if we are speculating, we could be wrong in guessing what we think is happening with that person. One of the most common things that's overlooked is changes in medical status. For example, an infection such as otitis media that could be leading to discomfort and then the aggressive or otherwise disruptive behavior. Seizure disorders are also very overrepresented in the DD population, so we really have to make sure that A, we're identifying seizure disorders that have not otherwise been identified up to that point in time, or if they're known to have a seizure disorder, to make sure that the management is optimal. And we should always keep in mind that medications, even though that they can do good things, can also do some things that we don't want, and so adverse effects from medications must always be ruled out. Just as a real brief overview of the seizure disorders in the DD population, it can be as low as 3 to 5% in neurofibromatosis type 1, and as high as 80% in Angelman syndrome, and even over 80% in tuberous sclerosis. So once we have evaluated, gotten a good history, physical, try to rule out all sorts of medical issues, we should start thinking about psychiatric disorders. If they are identified, they should be treated very specifically. And if those interventions, both medical and psychiatric, have not either reduced or eliminated the aggressive behaviors, then we need to reevaluate and look at all other things that might possibly be contributing to the behavior before we institute non-specific interventions, meaning sort of generic psychopharmacology. There was a study, or actually a meta-analysis, if you will, from the UK, published in November 2006, where they looked at all the studies that were done in the DD population with psychotropic medications. And what I decided to do is just focus on the ones that are either randomized controlled trials or randomized uncontrolled trials. The first up is the antipsychotics with both adults and children mixed. And there are 4 listed here. Zarcone in 2001, Vandenborre in 1993, Vason in 1981, and also in 1975. What was found is that there's mixed reviews and mixed feedback on the results. Although in general, it did seem that there was some response to the antipsychotics in these various mixed populations of DD and aggressive behavior. As far as children specifically, we have 5 studies that were listed here. One of them is the RUP, the Research Units on Pediatric Psychopharmacology, that will be presented in more detail by one of the other presenters. Again, we have fairly good evidence of decrease in disruptive and aggressive behaviors in that population. As far as antidepressants, there was really only one RCT. That was the use of clomipramine, and there was some improvement in stereotypical behaviors, which also may be related to the production of aggressive behaviors. As far as mood stabilizers and anti-epileptic drugs, there was one study. This was a randomized uncontrolled study with lithium, and it showed 68% improvement on that particular medication. Opioid antagonists such as naltrexone, one study, and RCT, no therapeutic effects. And I will comment on naltrexone later on in this talk. As far as stimulants are concerned, methylphenidate, an RCT, no therapeutic effect in reducing the various different target behaviors. So I'd like to start talking now about aggression in general. The risk factors that have been shown in the literature, fairly consistently. Number 1, male sex. So boys are much more likely to be aggressive than girls. And this is true even in the non-DD population. Age, aggressive behavior seems to peak in adolescence in this population. Placement, the higher level of care that people need sort of seems intuitive, but there is some correlation with impairment indirectly, but directly with placement status. Communication deficits, and we think that part of this is related to frustration, not being able to make their needs known, and just general frustration and boredom. So this really has implications for programming within these specialized settings. Other negative and undesirable behaviors can also contribute to aggressive activity, for example, oppositionality. And then, as I alluded to earlier, comorbid psychiatric disorders. Especially high on the list is autism or autistic features, depression, anxiety, mania, and psychosis. As I had mentioned about the high rates of seizure disorders in the DD population, there are also high rates of autism and autistic features. It can be as low as 1 to 10% in Down syndrome, 4% in neurofibromatosis 1, and very high rates in velocardiofacial syndrome, 20 to 50%, and also Cornelia de Lange syndrome, 36 to 62%. And the highest rate of autistic features in the DD populations that I looked at was in Smith-Magenis syndrome, which is 93% on average. All right, risk factors. We know that aggressive behaviors are much higher in certain syndromes that are associated with lower IQ. Some of these are relatively common, and some of them are really quite rare. And you'll be able to see from the slide that this includes Prader-Willi syndrome, fetal alcohol syndrome, Fragile X syndrome, Smith-Magenis syndrome, tuberous sclerosis complex, Cri-du-Chat syndrome, autistic spectrum disorders, and Down syndrome. I'm going to now talk about each one of those in some detail. First, Prader-Willi